आज ventricular tachyarrhythmia এবং closure of the chapter related to the discussion of arrhythmia आज की शेष दिन. Now, what is ventricular arrhythmia? According to anatomic origin, ventricular arrhythmia means arrhythmia with the origin below the level of the AV node as well as AV junction. That is the infrahish tachyarrhythmia. Ventricular tachyarrhythmia is virtually a myriad of arrhythmias that may occur in a normal heart or that may occur in a definite substrate, that means structural heart disease. So, myriad of arrhythmias that may occur in a normal heart or in an anatomic substrate, such as in a setting of structural heart disease. Myriad in the sense of clinical consequences also, it may be mild or benign in its nature, or it may be life-threatening, even leading to cardiac arrest and sudden cardiac death. Origin and mechanisms. Ventricular arrhythmias origin from a specific or particular anatomic focus. That means focal sites of origin, that is the focal myocardial cells or the Purkinje system capable of producing automaticity. That is the basis of focal tachyarrhythmia. But the cells, that means myocardial cells or the cells of the Purkinje system, also capable of producing triggered activity. So, first focal site of origin producing enhanced or augmented automaticity as well as the triggered activity. Or ventricular tachyarrhythmia may result from re-entry circuit. So, the three pathological processes like enhanced automaticity, triggered automaticity or activity, as well as re-entry circuits are responsible for genesis of ventricular arrhythmias. Re-entry circuit is a result of myocardial scar produced as a response to myocardial infarction, inflammation, or cardiomyopathic processes. But rarely, ventricular tachyarrhythmia may result from a disease involving the conduction pathway in the Purkinje network. So, pathophysiologic basis তার দুটো কম্পোনেন্টের কথা বলার চেষ্টা করছি. একটা হচ্ছে প্যাথোফিজিওলজিক্যাল মেকানিজমস, ওয়ান automaticity, number two triggered activity, number three re-entry circuits. Now, ventricular arrhythmia is characterized by electrocardiographic appearance and duration. Since ventricular activation is slow in comparison to normal activation through the normal conduction process or normal conduction system. So, the QRS complex is wide with a duration of 0.12 seconds or more. But there are unusual situations where narrow complex tachycardia may be present in a setting of ventricular arrhythmias. The classically ventricular tachyarrhythmia is a wide complex tachyarrhythmia with a QRS duration exceeding 0.12 seconds, but on occasion or in very unusual situations, it may be narrow complex tachycardia that is less than 0.12 seconds. Now, what are the different types of ventricular tachyarrhythmias? First of all, premature ventricular beats or premature ventricular contractions. And second, the ventricular tachyarrhythmia. That is, that may be monomorphic, polymorphic, that may be non-sustained, sustained, ventricular fibrillation and idiopathic ventricular arrhythmia. Now repeating ventricular tachycardia, monomorphic, ventricular flutter, polymorphic and ventricular fibrillation. Last but not the least, idiopathic ventricular tachyarrhythmia. So subdivision or types may depend on number one, the morphological appearance of the QRS complex. Number two, the pattern of the QRS morphology. Number three, the duration. And number four, the undulating baseline. Again, the different types of ventricular arrhythmia, premature ventricular contractions or premature ventricular beats, ventricular tachycardia, that may be monomorphic VT, ventricular flutter, polymorphic VT, ventricular fibrillation, and idiopathic ventricular arrhythmias. Now, premature ventricular contraction. What do you mean by premature ventricular contraction and what are the characteristics of premature ventricular contraction? A single ventricular focus producing a complex that occurs earlier than the next anticipated beat. So, a premature or single ventricular beats that occurs earlier than the next anticipated supraventricular beat. The features are premature, that means prematurity. Number two, abnormal morphology. Number three, the compensatory pause. The defining features of premature ventricular contraction means number one, prematurity, number two, abnormal morphology, and number three, compensatory pause, that is less than fully compensatory. The less than fully compensatory means the normal RR interval that surrounds the premature complex is less than twice the normal RR interval. RR interval encompassing or surrounding the premature complex is less than twice the normal RR interval. This is the less than compensatory pause. Prematurity means premature or earlier occurrence prior to the next anticipated supraventricular beat. Abnormal morphology means activation in the myocardium or the east Purkinje system with a wider QRS complex. So premature ventricular contraction has got three classical features: prematurity, abnormal morphology, and lastly compensatory pause, that is less than fully compensatory. Depending on the different sites of origin, Premature ventricular contraction can be subcategorized into two. A single focus or singular focus produces unifocal premature complexes, that is unifocal PVC. Whether the origin is different sites in the myocardium that may produce the multiple configuration of the QRS complexes or different QRS morphology or configuration known as multifocal. So premature ventricular contraction may be unifocal, may be multifocal, or may be complex. That means either in the form of couplets or in the form of greater degree of frequency. So categorization of premature ventricular contraction, we should consider several things. Number one, whether it is unifocal or multifocal. Number two, whether it is complexity in its nature. And third, the contour of the premature complex. These three are essential for the assessment or determination of the presence or absence of structural heart disease, which is crucial in the management strategy of premature ventricular contractions. Two consecutive ventricular beats are known as couplets, and each supraventricular beat is followed by QRS complex or premature contraction, which is known as ventricular bigeminy, that may produce a pseudo bradycardia because the ventricular premature people has got no ability to generate a separate pulse wave. That's why it is known as pseudo bradycardia. So couplets, an example of complexity contour, that means the sharp clean cut reflection is usually in the favor of non-structural heart disease, whereas broad with notching or slurring goes in favor of structural heart disease. This is the premature ventricular contraction. Normal sinus beat. This is a second normal sinus beat. This is the earlier occurrence number one. Compensatory pause number two, and this is the next normal sinus beat. So this is an example of ventricular premature contraction. যেহেতু each beat is followed by a premature contraction, this is known as couplets. On the contrary, in the next panel, the morphology of ventricular premature complex, it is the abnormal contour, not sharp deflection, followed by a left rabbit ear configuration, and the second premature complex, this is also sharp deflection followed by the sharp downward slope with ST segment. So this morphology and that morphology is totally different. This is the example of multifocal ventricular premature complexes. Now ventricular tachycardia. Three or more consecutive ventricular premature complexes at a rate exceeding 100 beats per minute constitute the diagnosis of ventricular tachycardia, whereas three or more ventricular premature complexes with a rate less than 100 beats per minute constitute a diagnosis of either idioventricular rhythm or accelerated idioventricular rhythm depending on the rate, but the rate is certainly less than 100 beats per minute. Ventricular tachyarrhythmia or tachycardia may be sustained or non-sustained. So what do you mean by sustained? Persistence of ventricular tachyarrhythmia less than 30 seconds is known as non-sustained or sustained. The duration of tachyarrhythmia is more than 30 seconds or is terminated by active intervention like electrical cardioversion, antiarrhythmic therapy, shocks from the ICD or catheter ablation, as well as anti-tachycardia devices. So, the ventricular tachycardia again subcategorized on the basis of duration, that is sustained or non-sustained, on the basis of morphology, that is monomorphic or polymorphic. When each QRS complex is similar from beat to beat, that means from beat to beat ventricular activation sequence is normal, indicating a common source of origin is known as monomorphic ventricular tachycardia. On the other hand, continually changing QRS complexes from beat to beat, indicating an multiple sites of ventricular activation sequence or is known as polymorphic VT that has got different sites of origin. Now the accelerated idioventricular rhythm, এখানে তোমরা লক্ষ্য করে দেখো প্রত্যেকটি ventricular complexes কিন্তু rate usually near about 100 beats per minute. This is not followed by the QRS complex. This is accelerated idioventricular rhythm. 3 or more consecutive ventricular premature complexes at a rate less than 100 beats per minute. Why it is accelerated? The automaticity of the ventricular myocardium is usually 40 to 60 beats per minute or even less than 40, but where the rate is more than 40, so it is known as accelerated. যদি রেট 40 or less তখন তাকে বলা হতো idioventricular rhythm. Monomorphic PP already described, same or similar QRS complex from beat to beat, indicating the activation sequence, the same from beat to beat, and each beat likely originates from a common source. Arrhythmias that originate from the right ventricular septum result in activation of much of the left ventricle is delayed that may produce a LBB configuration. On the other hand, arrhythmia that originate from the free wall of LV have a RVB configuration. So, ventricular tachyarrhythmia that may give an indication of the origin, especially either in the right ventricle or interventricular septum or in the LV free wall. The QRS morphology producing or in the form of RBP configuration means origin of the arrhythmia is in the L51. Whether QRS morphology similar to LBB configuration, the origin is in the right ventricle or in the interventricular septum. This is the repetitive monomorphic non-sustained ventricular arrhythmia. Non-sustained means duration of tachyarrhythmia less than 30 seconds. This is 3 consecutive premature ventricular contraction. This is the normal sinus rhythm. Again, this is the more than 3 premature ventricular contraction. So this is a classical example of monomorphic, non-sustained because duration is less than 30 seconds ventricular tachyarrhythmia. Site of ventricular tachyarrhythmia on the basis of QRS morphology. The right ventricle, the V1 LBB, that means left bundle branch block configuration. In contrast to that, whether or when it arises from the L51, there is the RBB configuration. That means R is R' configuration. So RV or interventricular septum LBB configuration, L51 RBB configuration of the QRS complexes. Ventricular flutter. What is ventricular flutter? Very rapid, regular ventricular tachycardia that is monomorphic, producing a sinusoidal appearance which known as ventricular flutter. Ventricular flutter is always monomorphic. Now, the very rapid monomorphic BT with sinusoidal appearance, and it is not possible to differentiate the QRS complex from the T wave. This is the classical undulating or sinusoidal appearance, an example of ventricular flutter. Common cause hyperkalemia, antiarrhythmic drug toxicity, and the severe global myocardial ischemia. Hyperkalemia toxicity from the medication or drugs, especially class 1A antiarrhythmic drugs like flecainide, propafenone, or antipsychotic drugs like phenothiazine or tricyclic antidepressant, as well as global severe myocardial ischemia. All are responsible for the genesis of ventricular flutter. This is a very rapid monomorphic ventricular tachycardia. Polymorphic VT. Continually changing QRS morphology indicating a changing ventricular activation sequence. That is the reflection of origin from different sites in the myocardium. Polymorphic VT occurs in the setting of QT prolongation syndrome that may be acquired or that may be genetic, and that may produce a shifting axis of the QRS complex and twisting of the tip of the QRS complexes. that is known as Torsades pointes. This is an example of polymorphic VT. This is the continually changing QRS complexes, QRS complex, QRS complex, QRS, all are not similar in their morphology. So different or dissimilar morphology tachycardia is known as polymorphic VT. Ventricular fibrillation. এখানে একটা কথা মেনশন করা উচিত, ফ্লাটারটাকে রাখা হয়েছিল ইন ক্লাসিফিকেশনে যে মনোমরফিক ভিটি, তারপর ফিব্রিলেশনকে রাখা হচ্ছে পলিমরফিক ভিটি এবং তারপর, যদিও মনোমরফিক ভিটি as well as polymorphic VT may degenerate or terminate into the ventricular fibrillation as well as cardiac arrest and sudden death. Continuous irregular activation with no discrete QRS complexes. Continuous irregular rapid activation with no discrete QRS complexes. Much more common in polymorphic ventricular VT, but monomorphic as well as polymorphic ventricular tachycardia may degenerate into ventricular fibrillation. Cardiac ischemia is the most common cause of ventricular fibrillation. Repeat, cardiac ischemia, or more precisely myocardial ischemia, is the most common cause of ventricular fibrillation. Now, the premature ventricular contraction and non-sustained ventricular tachyarrhythmia. Premature ventricular contractions already discussed may be due to enhanced automaticity, re-entry, or triggered activity. Re-entry নিয়ে দুটো কথা বলার প্রয়োজন বোধ করছি। Polymorphic or unifocal or multifocal ventricular premature complex, or polymorphic or monomorphic tachyarrhythmia. What is the status of the re-entry circuit? In case of unifocal premature ventricular contraction or unifocal or monomorphic VT, there is a fixed anatomical or functional re-entry. On the other hand, in case of multifocal PVC or polymorphic VT, there are several re-entry circuits in the different regions of the myocardium. PVC are often sensitive to sympathetic stimulation and can be a sign of increased sympathetic tone, myocardial ischemia, hypoxemia, electrolyte imbalance, as well as underlying heart disease. During myocardial ischemia or in association with other structural heart disease, PVCs, that means premature ventricular contractions, are harbinger of the sustained ventricular tachycardia or ventricular fibrillation. Show the clinical significance of premature ventricular contraction is in a setting of structural heart disease or in a setting of risk factor associated with sudden cardiac death. Premature ventricular contraction may be a harbinger of sustained ventricular tachycardia or ventricular fibrillation. The ECG characteristics of the arrhythmia often suggestive of whether structural or disease is present or not. PVC with smooth uninterrupted contour and sharp QRS deflections. QRS with smooth and uninterrupted contour plus sharp QRS deflection usually signify absence of structural or disease, whereas broad notching or slurring either in the downslope or upstroke of the R wave is a reflection of the presence of structural or disease. The QRS morphology also suggests the likely site of origin within the ventricle. PVC have a dominant shape in V1, there is the LBB pattern or originate from the right ventricular septum or interventricular septum. এটা অনেক আগে ক্লিয়ারলি বলে দেওয়া হয়েছে RV or IBS LBB configuration, LB free wall, RBB configuration. Now, idiopathic ventricular arrhythmia. Now, management ventricular premature complex and non-sustained arrhythmia that may occur in an acute illness, that may occur in a setting of coronary artery disease, that may occur in a setting of congestive heart failure, that may occur in a setting or of other associated genetic arrhythmias, and depending on the association and comorbidities, the management of ventricular premature complexes or non-sustained arrhythmia is indicated. In acute illness, especially in a subject hospitalized for some other reasons, there may be transient occurrence of ventricular premature complexes because of electrolyte imbalance, hypoxemia, and certain other conditions that may not require any sorts of therapy, even in case of non-sustained arrhythmia. But when there is high risk of sudden cardiac death or family history of genetic arrhythmias or premature cardiac deaths, additional evaluation is necessary for the correct diagnosis of non-sustained ventricular tachyarrhythmia. What is the genetic syndrome associated with arrhythmia? Usually that include long QT syndrome, Brugada syndrome, arrhythmogenic right ventricular cardiomyopathy, several cardiomyopathies, especially hypertrophic cardiomyopathy. Treatment of idiopathic arrhythmias. Idiopathic arrhythmias means either PVCs or non-sustained ventricular tachycardia in absence of any structural heart disease, with normal ECG and normal cardiac function, as well as structure detected by echocardiography or cardiac magnetic resonance imaging. অর্থাৎ সহজ পরিভাষায় idiopathic ventricular arrhythmia means absence of structural heart disease. Number 2, normal electrocardiogram Number 3, functional and structural abnormalcy is absent by means of echocardiography or other imaging like cardiac magnetic resonance imaging. Management, whether asymptomatic or minimal symptoms, no therapy is indicated. But when it is associated with the complexities of the premature complexes or risk of degeneration into VT or PP, therapy is indicated in the form of either anti-arrhythmic therapy, catheter ablation, electrical cardioversion, and others. Management of non-sustained arrhythmia in a setting of myocardial infarction or ischemic heart disease. এখানে আমরা তিনটা ক্যাটাগরিতে ভাগ করব। পেরি এমআই পিরিয়ড, সেকেন্ড হচ্ছে ফলোইং রিকভারি, and third হচ্ছে usually the follow-up phase, and fourth in the setting of congestive heart failure. Peri-infarct period, cardiac revascularization and management of the myocardial infarction will abolish the non-sustained VT and premature ventricular contractions. No therapy is usually indicated. But in disabling situation or risk of degeneration into arrhythmias or a history or episode of a single sustained ventricular tachycardia or VF, therapy is indicated in the form of amiodarone. Beta blocker may reduce or suppress. Beta blocker may reduce the mortality rate in the form of sudden death, but does not have any impact on the arrhythmia. So, peri-infarct period, no definite therapy is usually indicated, but when there is chance of transformation or degeneration into the VT or VF or a single episode of VT or VF warrants drug therapy in the form of amiodarone. Beta blocker may reduce the sudden death, but overall impact on the arrhythmia is unknown, basically not useful. Second, following recovery or during the resolution phase of myocardial infarction. Post-MI more than 40 days old with LV ejection fraction less than 30%, or MI more than 40 days old with LV ejection fraction less than equal to 35% with NYHF functional class HF 2 or 3, therapy is indicated in the form of ICD, or post-MI more than 5 days old and reduced ejection fraction, as well as detection of the wall motion abnormality and evidence of inducible VT or VF. Inducible VT or VF, ICD is essential. And lastly, the PVC and non-sustained ventricular tachyarrhythmia, that is congestive heart failure. During the discussion of congestive heart failure in the past, HF or EF with ejection fraction less than equal to 35%, and in YHA function class 2 or 3, ICD is indicated. That's all regarding the management of premature ventricular contraction and non-sustained ventricular tachyarrhythmia. Sustained ventricular tachyarrhythmia, arrhythmia with a wide QRS complex lasting more than 30 seconds, requiring an intervention for its termination. Each quartz complex resembles the others, that means it may be monomorphic or it may be polymorphic depending on the site of origin and the complexity of origin. The mechanisms is again automatic focus or re-entry circuit. In case of monomorphic fixed re-entry circuit or a single or similar automatic focus. In case of polymorphic PP, a multiple re-entry circuits or changing or different automatic focus. And what is the substrate for the re-entry? Area of patchy replacement fibrosis due to myocardial infarction, inflammation or fibrosis. এক্ষেত্রে একটা কোশ্চেনের মুখোমুখি হতে পারি যে আগে ফাইব্রোসিস বললেন, আবার এখানেও ফাইব্রোসিস কথাটা মেনশন করেছেন। আমি বলেছি প্যাচি রিপ্লেসমেন্ট ফাইব্রোসিস ডিউ টু myocardial infarction, fibrosis, inflammation, or post-cardiac surgery that may produce anatomic or functional re-entry circuits. Because I told the replacement fibrosis, that's why এই লাইনে দুটো ফাইব্রোসিসের কথা মেনশন করা হয়েছে। Less commonly, VT is related to the re-entry or automaticity in the conduction pathway of the Purkinje system. যে কন্ডাকশন পাথওয়ে অফ দ্য পার্কিনজি সিস্টেমটাকে কেন বলছি এটা কিছুক্ষণ পরেই বোঝা যাবে। ফ্লো ট্র্যাক্ট অফ অরিজিন, আউটফ্লো ট্র্যাক্ট অরিজিন, আরপি আউটফ্লো ট্র্যাক্ট অরিজিন usually in the vicinity of the valve annulus. LV tract, LV outflow tract origin, and then the LV fascicular VT, then papillary muscle VT. So idiopathic ventricular tachycardia, that means without structural heart disease, subcategorization, outflow tract origin. Again, the components RV outflow tract, LV outflow tract. Second, LV fascicular origin. Third, papillary muscles, either posteromedial or anterolateral. Then comes the ischemic cardiomyopathy that may produce monomorphic or polymorphic. Then non-ischemic cardiomyopathy that again produce polymorphic PP or monomorphic, but polymorphic VT is more common in non-ischemic cardiomyopathy. Then arrhythmogenic RV cardiomyopathy, again monomorphic or polymorphic VT or PF. Then repair tetralogy of Fallot, usually monomorphic with RBB, with ABB configuration, and hypertrophic cardiomyopathy, polymorphic VT or ventricular fibrillation. And lastly, the genetic arrhythmia syndrome. Again, one long QT syndrome, Torsades, T-pointies, VT or VF, Brugada syndrome, ventricular fibrillation, especially nocturnal, catecholamina cheek VT or bidirectional VT, catecholamina-cheek VT or bidirectional VT। যে কথাগুলো আমি রিপিট করছি সেই কথাগুলোর গুরুত্বটা বেশি, যেগুলো রিপিট করছি না সেগুলো গুরুত্ব কম। Catecholamina-cheek VT or bidirectional VT, long QT syndrome, Brugada syndrome, etc. and short QT syndrome and early repolarization syndromes. So genetic arrhythmia syndromes, long QT syndromes, Brugada syndrome, catecholamina-cheek polymorphic VT, short QT syndromes producing ventricular fibrillation, and definitely কোনো কিছু খুঁজে না পেলে idiopathic polymorphic VT or ventricular fibrillation, idiotic for the physician and pathetic for the patient. That's why idiopathic. Now repeating. Idiopathic ventricular tachycardia, outflow tract origin, RV outflow, LV outflow. LV fascicular VT, papillary muscle VT. Then ischemic cardiomyopathy. Then non-ischemic cardiomyopathy. Then arrhythmogenic RV cardiomyopathy. Then repaired pathology of fallow. Then hypertrophic cardiomyopathy. 7. Genetic arrhythmia, long QT, Brugada, catecholamina-cheek, short QT, and early repolarization syndromes, idiopathic polymorphic VT or ventricular fibrillation. Clinical presentation depends on the rate of arrhythmia, duration of arrhythmia, status of the cardiac functional as well as structural component, and lastly autonomic adaptation to the response to arrhythmia. So clinical presentation depends on the rate of the arrhythmia, duration of the arrhythmia, background cardiac disease, and autonomic adaptation to the response to arrhythmia, and may include symptoms: palpitation, dizziness, sense of lightheadedness, even sudden cardiac arrest leading to sudden cardiac death if not resuscitated adequately or in time. Diagnosis: sustained monomorphic VT has to be distinguished from other causes of wide complex QRS tachycardia. কি হতে পারে? Supraventricular tachyarrhythmia in a setting of right bundle branch block or left bundle branch block, or supraventricular tachyarrhythmia with conduction over the accessory pathway may produce wide complex tachycardia. So, wide complex tachycardia may be ventricular tachyarrhythmia or ventricular tachycardia, or supraventricular tachycardia with aberrancy, that means aberrant conduction over the accessory pathways or in the setting of either RBB or LBB. The features কে দুটো ভাগে ভাগ করা যায়। একটা হচ্ছে Brugada criteria supported by the QRS morphology criteria, কিন্তু এখন ওগুলোকে সামারাইজ করে বা ইনকর্পোরেট করে একটি সিঙ্গেল অ্যাপ্রোচ বা অ্যাসেসমেন্টে আসা যেতে পারে। ফার্স্ট অফ অল, মোস্ট ইম্পর্টেন্ট ইজ VA dissociation or AB dissociation. Second is the R monophasic R or RS, that means tall R, small s in AVF goes in favor of ventricular tachyarrhythmia. or concordance pattern from V1 to V6 of QRS complexes by either monophasic R or S is suggestive of ventricular tachyarrhythmia. Presence of fusion beats, presence of capture beats goes in favor of ventricular tachyarrhythmias. So AV dissociation, concordance pattern, monophasic R or tall R small s in AVR, as well as presence of the fusion beat and capture beats, all are in favor of ventricular tachycardia rather than supraventricular tachycardia with aberrant conduction. Now coming to the point of discussion, AV dissociation, yes. VT, no. AVR, monophasic R or tall R small s is VT, no. No S or RS in any of the V1 to V6 VT, no. SVT with aberrancy, but VT is still possible. Is a Torsades pointis, a polymorphic VT, occurs in the setting of QT prolongation. That may be accord, that may be congenital. Accord a কারণ হচ্ছে one antiarrhythmic medication, especially quinidine or class 1 antiarrhythmic drugs. Antipsychotics like phenothiazines or tricyclic antidepressants. Antibiotics like macrolides such as erythromycin, clarithromycin, etc. এমনকি cerebrovascular accident like CVA or subarachnoid hemorrhage, etc. etc. It is যাচ্ছে না. Example, Torsades pointis. Activation sequence is usually a premature ventricular contraction followed by a pause, then appearance of a supraventricular beat, then the wide QT interval and the sudden appearance of the initiating ventricular premature complex. Example, this is the ventricular premature complex with a long pause, appearance of the supraventricular premature beat with long QT interval and the sudden occurrence of a spontaneous premature ventricular beat before completion of the T-wave, the initiating trigger of the polymorphic VT with twisting of the QRS point known as Torsades pointis. This is pause-dependent polymorphic ventricular tachycardia. Torsades pointis. Now, electrical storm, that means episodes of 3 or more VT or VF within 24 hours. Occurrence of 3 or more episodes of VT or VF within 24 hours. That warrants intervention for termination. This severe electrical instability is associated with a higher mortality unless or until interrupted by therapeutic intervention. and a form incessant VT. That means recurrence of VT or VF shortly after reversion of VT or VF to sinus rhythm, either spontaneous or by means of activation. That means rapid recurrence after successful termination to sinus rhythm. Within a brief period, the termination may be either spontaneous or by means of intervention like antiarrhythmic therapy or electrical cardioversion or other device. Incessant ventricular monomorphic tachycardia. This is a VT anti-tachycardia patient VT termination. This is the terminated DB. Again, the appearance spontaneous recurrence. So this is the episode of the VP, institution of the therapy. This is the sinus rhythm followed by rapid recurrence. ঠিক হয়ে গেল আবার সঙ্গে সঙ্গে রিঅ্যাপিয়ার করলো। This is the incessant. Strategy for management of the electrical storm. Classical paternage stabilization of the rhythm by means of defibrillation, amiodarone, lidocaine, mexiletine, on occasion quinidine, as well as procainamide and catheter ablation. Second, relief of triggers or elimination of the triggers. তার মধ্যে থাকছে correction of the dyslexolithiamia, volume resuscitation in the form of removal of the volume overload and the coronary revascularization. So, stabilization of the rhythm, relief or elimination of the triggers, and lastly, the reduction of the sympathetic drive. সেগুলো কি? Beta blocker, sedation and anesthesia, anxiolytic. Beta blocker, anxiolytic, sedation and intubation. That means that are designed to reduce the sympathetic drive or stellate ganglion block or cardiac surgical denervation. Cardiac surgical denervation. Again, stabilization of the rhythm, relief of triggers, then reduction of the sympathetic drive that may include beta blockers, anxiolytics, sedation and intubation. Again, the stellate ganglion block or lastly, cardiac surgical sympathetic denervation. Cardiac surgical sympathetic denervation. Now, in short, electrical storm, that means 3 or more episodes of VT or VF. VT or VF again subdivided and management depends on the etiologic basis. Monomorphic ventricular tachycardia, beta blocker, amiodarone, lidocaine, sedation, etc., etc. Second, long QT accordingly, or normal QT or ischemic accordingly, PVC initiated accordingly, and Brugada syndrome accordingly, inflammatory, ekhane steroid pulse followed by beta blocker or amiodarone, on occasion stellate ganglion blockade. Question: Brugada syndrome, এটাকে বলে দিচ্ছি। Elevation of the ST segment 0.2 millivolt or more in one or more anterior precordial leads, especially V1 or V2, with the scoped ST segment anti-wave inversion coved ST segment and tube inversion. ST segment elevation of 0.2 millivolt or more in V1 or V2 with coved ST segment and tube inversion. This is the type 1 Brugada syndrome, usually produce ventricular fibrillation or polymorphic ventricular tachycardia, especially nocturnal, may occur in sleep apnea. And the Brugada syndrome may be of 3 types. Type 1, that is the coved ST segment. Type 2, that is the saddleback ST segment in V1 or V2. And type 3, the intermediate configuration between the saddleback and coved. This is the type 3. But the result is same. This is the type 1 coved ST segment. This is the type 2 saddleback coved ST segment. And this is the type 3 in between configuration saddleback. Even saddleback configuration. আরেকটা ছবি ছিল ক্যাটেকোলামিনার্জিক, এইটা বলতেই হবে। ক্যাটেকোলামিনার্জিক ভিটি স্লাইড বানানো হয়। ক্যাটেকোলামিনার্জিক ভিটি বানা হচ্ছে যে usually drug toxicity, especially digitally drug toxicity setting, polymorphic ventricular tachycardia, that is bidirectional, that is with alternating QRS morphology. Alternating QRS morphology, white complex polymorphic tachycardia is known as bidirectional tachycardia, is usually due to drug effect, especially digitally toxicity. That's all.